Sir is like the principal of the Amrita School of Medicine, and he's also the head of the Department of Emergency Medicine, and in the Kochi. And he is recognized as one of the pioneers in the emergency medicine in India. I guess he has published a lot of books, and he is running the YouTube channel, and it has a very million followers and subscribers. And even I have followed that videos of you, sir. It gives
Thank you.
like a lot of things. Like it helps us in streamlining our approach towards the patients.
Thank you.
And Sir is like first person to start the emergency medicine in the emergency medicine specialty in Kerala. So he is trained extensively in the emergency medicine, like both the emergency medicine and the acute trauma. And he has not only treated many patients, but he has also made many emergency doctors. And one more thing is that Sir was my external examiner when I was doing my post graduation. So it is truly a honor and privilege to welcome you today and have you today, sir.
Thank you. Thank you.
We are welcoming. We are truly looking forward to this informative session, sir.
Okay. Can we start now?
Yes, sir. We can start.
Okay. Thank you for inviting me for this session. Today's topic given to me is hyponatremia in emergency department. You should tell me the time. You should remind me about the time. I'll finish it in 20 minutes, but if I'm going exceeding that time, please let me know.
Yeah, sure, sir.
Hyponatremia is one of the most common problem in emergency room. When you are practicing in emergency room, you will understand that most cases in emergency medicine department, they may come with various other problems, but hyponatremia will be always there in that patient. Whether it is clinically significant or not, that we have to find out. So when you see the definition of hyponatremia, if the sodium levels are less than 135, then you can call it as hyponatremia. But that doesn't mean that 135 is a range where that onwards patient will deteriorate. It is not like that. It depends on a lot of other factors also. And if you see true hyponatremia, that means that on the go, we'll discuss all these things. Hypoosmolality has to be there. There are conditions where hyperosmolality, normosmolality, all those things can be there. But if the sodium in the blood is low, the osmolality will be very low. That is very important. And you should also see some of the conditions like pseudo-hyponatremia. Normal osmolality, that is hyperlipidemia, hyperproteinemia. You can get conditions like patients' cholesterol levels are very high, like multiple myeloma and all. You can get sometimes like this. Hyperosmolality means normally when you treat DKA or HHS, you can see this type of conditions. So we will not be concentrating in this type of hyponatremias. We'll be concentrating in real hyponatremia or true hyponatremia. So if you see this picture, you'll understand what is hyponatremia with normal ECF, hyponatremia with increased ECF, hyponatremia with low ECF. We'll see some of the conditions like hyponatremia with normal ECF. Suppose a patient who is having only sodium loss or is not taking sodium at all. This happens mainly when the patient is first time diagnosed to have hypertension, and doctor may advise to take less salt. Unfortunately, most of our patients, especially elderly individuals, they don't take salt at all in hypertension. So in that type of patients, you can get hyponatremia with normal ECF. Second one is hyponatremia with increased ECF or hypervolemia. In that condition, you can see peripheral edema, patient will be blotted up. That is mainly seen in patient who is having cardiac failure, liver failure, kidney failure. All these conditions, wherever there is volume overload is there, you can get this type of things. Last one is hyponatremia with low ECF. If the patient is losing large amount of water with sodium, like severe diarrhea, vomiting, water loss, sweating, all these things, you can get like this. So three types of hyponatremia we have already discussed: hyponatremia with normal ECF, hyponatremia with increased ECF, hyponatremia with low ECF. In that one condition I didn't mention in the last slide, that is SIADH. We'll discuss it afterwards because SIADH is not a common problem. If you discuss now, you may not understand the problem afterwards. So SIADH is a separate problem that we'll discuss afterwards. Okay. So SIADH is a syndrome where inappropriately antidiuretic hormone is released. Inappropriately, that doesn't mean that it is not a like excess production. It is an unwanted production. That is very important. Persistent ADH release, water retention can be there. in SAIDs. But normally in the textbooks, what we learn is SAIDs means there is no water retention, there is no edema. We are not seeing edema, that's all. But patient is having water retention. That is very important. The mechanism I have given in the last part, how SAIDs will not have a excess volume, a clinically significant excess volume will not be there, but definitely patient is having a volume excess. That's why you are getting hyponatremia. The major cause of SAIDs is CNS infections like meningitis, tumors, malignancy, especially lung cancer. Some drugs can produce SAIDs or post-surgery. We have to also rule out hypothyroidism, kidney disease, all these things. Remember, most of the patients come to emergency room is not SAIDs. Very rarely you can get SAIDs. That is not a common diagnosis. Common diagnosis, patient is not taking salt or patient is losing excess salt due to some other reason. One of the reason where you lose excess salt is urinary tract infection, which may not be given in standard textbooks. That also you should remember. It resembles like SAIDs. You have hyponatremia, you have excess urinary loss of salt. That is typical feature of SAIDs. But the most common condition where we get SAIDH-like feature is urinary tract infection. So in urinary tract infection, large amount of sodium is lost through the kidneys. So that also comes near to SAIDH, but it is not actually SAIDH. Now, clinical features, say salt or hyponatremia, salt deficiency or hyponatremia, it mainly affects your CNS system. So mild hyponatremia patient can have anorexia, headache, nausea, vomiting. Moderate hyponatremia, you can have personality change, muscle cramps, muscle weakness, confusion. Severe hyponatremia, you can have drowsiness, diminished reflexes, convulsions, coma. Whatever it is, whenever patient is having hyponatremia, the most clinically significant symptom will be weakness. Some patients can have altered behavior, low GCS. Later, some of them can develop even seizures. But the main clinical picture in emergency room, what you are going to see is weakness. Any patient, especially elderly, coming to your ER with weakness, you are supposed to check the sodium levels of that patient. That is the number one investigation to be done after your blood sugar. Anyway, in emergency room, most of the patients, we are doing blood sugar. That is the first investigation. Second investigation in a patient who is having weakness. Neurological weakness mean that doesn't mean that hemiparesis we should suspect hyponatremia. Generalized weakness, one of the common cause will be hyponatremia. Now, in a patient with hyponatremia, we should do some minimum investigation and we should make a diagnosis. In that, if you might have seen that previous slides, we have three different types of hyponatremia: normal osmolality, hypoosmolality, and hyperosmolality. But if the sodium levels in your blood is actually low, the osmolality will be low. That is true hyponatremia. Osmolality will be less than 270 millimoles per kg. So if you have a hyponatremia, the first investigation you should ask is plasma osmolality. Before that, you have to clinically judge whether the patient is having volume excess or volume depleted or normal volumic. That clinically only you can find out. You can also use some of the clinical modalities like ultrasound and all to know the IVC collapsibility to see whether the patient is having volume depleted or volume excess is there in the body or not. That can be done. But here, if the sodium levels are actually low, you can tell that it is a true hyponatremia. The osmolality will be less than 270. So if the sodium levels are less than 270 or 280, some books give less than 270, some books give less than 280. That doesn't matter. If the osmolality is really towards 270, 280, you can understand that it's an actual hyponatremia. So that only will be evaluating properly. Now, then second two investigations. One is serum osmolality will be low if the sodium is actually low. The two other investigation you are supposed to do is urine sodium concentration we have to do, urine osmolality you have to see. Because I already told that there are few important reasons in emergency room where you can get hyponatremia. One patient is not taking salt, depletional hyponatremia. One patient is having excess volume. That means cardiac failure, liver failure, all these things. Third one is loss of sodium through the kidneys. So when the patient is not taking normal salt, when the patient is not having excess volume, the next set of investigation will be you have to check whether the urine sodium concentration is high or not. If the patient is having true hyponatremia, body will try to prevent the loss of sodium through kidneys. So the sodium levels in the kidneys through the urine loss will be less than 20. That is very important. If the patient is having actual hyponatremia, body will try to preserve sodium. So if the patient is having hyponatremia and if the urine loss is less than 20 milliequivalents, then kidney is not the culprit. It is something else. If the patient is having hyponatremia and if the sodium levels in the urine is more than 20 milliequivalents per liter, then the reason is kidney is losing salt. It can be SIADH, like we discussed, salt wasting nephropathy. There, water is also lost through the kidney. Diuretic therapy, hypoaldosteronism. These are the common reasons. But remember, one reason which is not given in the textbook is it is urinary tract infection. If you see any patient who is having urinary tract infection, you will get all these features of SAIDs. Patient can have patient can have hypoosmolar hyponatremia, increased urine sodium, and increased urine osmolality. If you treat the urinary tract infection, patient will recover without any major issues. So the other investigation will be urine osmolality. You all know that when the sodium levels in the urine is very high, the osmolality naturally increases more than 100 milliosmol per kg. So two important investigations. One is serum sodium and serum osmolality, urine sodium and urine osmolality. These are the two important investigations you do in hyponatremia. And we have discussed the same thing in the previous slides: hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia. This should be clinically judged. So whenever you get a patient who is having hyponatremia, clinically see whether the patient is having any volume excess. You can clinically or ultrasound wise, you can find out whether the patient is having volume excess. Then look for any dehydration signs. That is also important. Then if the patient is not having any signs of hypervolemia or hypovolemia, it is euvolemic. Then one of the conditions which can produce euvolemic hyponatremia is SIADH, that we have discussed, and that is not a very common cause. One of the common cause which mimics SIADH is urinary tract infection. Here afterwards, every urinary tract infection you track, patient can have some hyponatremia, patient can have excess urinary loss, patient can have increased urine osmolality. Everything will be there, but that is not SIADH, and it will not be given in most of the standard textbooks. Now, other hyponatremias we are not going to discuss, but remember, if the patient is having high blood sugar like DKA or HHS, DKA, you can get hyponatremia. That is because of the high blood sugar. HHS also you can get hyponatremia, but because of the severe dehydration, some of the patients can have high sodium also. So DKA is one of the classical condition. Because of high blood sugar, you can get hypertonic hyponatremia. Isotonic hyponatremia, that is commonly seen in hyperlipidemia and hyperproteinemia. That is clinically not relevant. You may not get this type of cases in routine clinical practice, but rarely, if you're working in a oncology center, you may get this type of cases. Now, how do you investigate a case of hyponatremia? First, see the plasma osmolality. Just follow the flow chart. You look at the plasma osmolality. If it is low, then it is true hyponatremia. Then look at the volume status in that patient, whether it is increased, decreased, or normal. So if it is increased, look for any failure: cardiac failure, liver failure, nephrotic syndrome with hyperproteinemia, anemia with volume overload, renal failure with volume overload. So all these conditions, one standard thing is, one common thing is volume overload. Then if it is decreased, if volume is decreased, then check the urine sodium. So remember that one important thing, whenever body is having low sodium, body will try to prevent loss of sodium through kidneys. That is very important. So if the sodium levels are less than 20 milligrams, it's extra renal loss like diarrhea, vomiting. If the sodium levels are more than 20, it's a renal loss, salt wasting, nephropathy, diuretic therapy, hypoaldosteronism. Then if volume status, clinical volume status is normal, it can be SAIDH. You have to rule out hypothyroidism and adrenal failure. But remember, actual volume in the body is high in SAIDH, but because of some counter-regulatory hormone mechanism, the volume is slightly removed, but still patient is having excess volume. That's why in the treatment, we'll see that SAIDH, the main treatment is stop giving fluid or fluid restriction. That is a treatment of choice. Now we can see the management. So management also depends on the clinical finding that we'll discuss afterwards. But hyponatremia, if the patient is having dehydration, you can give volume, like normal saline is the ideal choice. If the sodium levels and volume levels, like dehydration is there in the patient, normally in emergency room, we give normal saline. That is a treatment of choice. Don't try to give 3% saline in a patient who is having severe volume depletion with hyponatremia. The choice of the treatment here is normal saline. If the patient is having hypervolemia with edema, you can remove some of the fluid by diuretic. Don't think that sodium also will lose through the kidney when you are giving diuretic. Here the problem is excess volume, not low sodium. The sodium is actually normal. Volume is excess. If you can remove some amount of volume, the sodium levels can become normal, and you restrict the fluid to 1 to 1.1 liter and per day. And salt restriction also will be very, very important, because if you add salt to a patient with volume excess, The problem will be patient can have more water retention in the kidneys. So try to reduce the salt. That doesn't mean that don't give salt. That is a problem when you are advising the patient. If they don't understand, they'll completely stop the fluid, completely stop the salt. So you have to tell that if you are telling salt restriction means it can be 2 to 3 grams. That's all. Very minimal salt, not like what we take 6 to 8 grams or normal salt we take every day. That should not happen. And normovolemia also. So normovolemia, I mean that here it is SIADH. SIADH, actually the treatment is water restriction because there is water retention in the body. Now, in a patient who is having sodium deficiency, the treatment is you have to give oral salt. That is the best thing. You have to treat the patient as a physiological human being. So physiological treatment is always better. You give salt to the patient, but you know that we cannot take too much salt in our diet. It will not become, it will not be edible then. The taste will alter. So better to give salt in. So what we do routinely is we break the B complex tablet and put the salt inside and give to the patient. So it will be palatable. They can take the diet. Adding too much salt to the diet may not be feasible in normal settings. But each teaspoon of salt, sodium chloride is 6 grams salt. In a day, knowingly or unknowingly, we'll be taking around 6 to 8 gram in a routine diet. Okay, so we have to give excess salt to the patient. You may have to give 1 or 2 teaspoons of salt to give a extra salt to the patient. So that can be tried if the patient is having patient is taking normal diet. Now, if the patient is having hyponatremia with hypovolemia, like diarrhea, dehydration, vomiting, severe sweating, heat stroke, all these things, we can try normal saline. Normal saline contains, you can see the comparison chart here. Normal saline contains nearly 154 milliequivalents of salt in 1 liter. So you can give normal saline once the patient is having adequate fluid with salt. If the patient is not improving in his sodium status, you can along with your normal saline, you can give oral diet, oral salt, and you can also try 3% saline. But initially, you should never try 3% saline. That is not an advisable treatment. I will tell what are the indications for 3% saline afterwards. Now, 3% saline should be given if the patient is having severe sickness because of hyponatremia. And if you are not able to correct with normal saline or oral salt, and or it should be a medical emergency, like an emergency room patient is having severe seizures, or patient is having severe altered behavior, low GCS, severe weakness, unable to move. All these conditions, we can try 3% saline. Otherwise, it is not a very good choice, but you can still give it in a lower dose if suppose you want to give. But how to calculate the required sodium, that is very, very important. So blindly never start 3% saline. You have to calculate and give 3% saline. So calculation, I'll tell you, desired sodium minus serum sodium, what you are getting from the patient's lab investigation, into 0.6 into body weight. That is a body water. So desired sodium minus serum sodium, always you keep it as 8 or 10. Don't try to correct more than 8 to 10 milliequivalents in a day. Into 0.6 into body weight will give you the amount of salt required for correction. So each 100 ml of 3% saline contains 51.3 milliequivalents. That is very important. So if you want to correct the sodium deficiency in a patient with hyponatremia, first of all, you calculate the deficiency, then try to give 3% saline according to the dose given in this chart. So I'll show the next chart. We have an example here. 50-year-old male patient, 70 kgs body weight with a sodium level of 110 milliequivalents. So normally we try to correct only 8 to 12 maximum, 8 to 12 milliequivalents in a day. So here I wanted to correct this patient's sodium by next day 122 milliequivalents. That means 12 maximum. That is a maximum. Normally we correct 8 to 10. That's all. This is the maximum. Just for example, I am showing it. So 122 minus 110. That is the patient's sodium level. 0.6 into 70 kg. That is the weight of the patient. Then 12 into 42, you are getting somewhere around 500 milliequivalents of salt replacement. Each 100 ml 3% saline, that is one bottle, is having 51.3 milliequivalents of sodium. So how much bottles you are requiring to correct the sodium deficiency is given here. So that is around 9.8 bottles or 10 bottles. You take it as 10 bottles. 10 bottles are required. So 10 bottles of 3% saline. That means 1 liter of 3% saline is required to correct this patient's sodium deficiency. But remember, some of the things when we are calculating, you may get 10 liters, but even after correcting, after giving 600 or 700, it may get it corrected or overcorrected. So you have to be very careful. You can check the sodium levels every 4 to 6 hours. If there is no emergency, you should not treat it fast. You should give it as a slow infusion around 8 to 10 millicurrent only. You should correct over 24 hours. So you can calculate it easily. And if the sodium correction within 24 hours, we have achieved 122, in this case, we have to stop the infusion. No need to continue after that. No need to correct more than 12 millicurrents in that day. You have to look the patient. If the patient is clinically stable, clinically improved, then better to stop the infusion and wait for the next day and restart the infusion according to the sodium levels in that patient. Now, there are some conditions we have to give bolus 3% saline. In patients who is having severe altered behavior, coma, seizures, especially seizures, you can give IV push of 3% saline, 100 ml or 10 to 60 minutes can be given. 2 ml per kg per hour can be given according to standard protocol, but very rarely this will happen. But if at all patient is having severe comatose state or severe seizures, which is uncontrolled with your routine medications, you should try this. There are complications can happen in these patients, but here it is an emergency. We have to give IV push. Now, if we correct fast in a patient who is having hyponatremia, especially chronic hyponatremia, what will happen to the patient? That is very important. There is a condition called as osmotic demyelination syndrome. Previously, it was called as central pontine myelolysis. Now we know that osmotic demyelination syndrome can happen at any part of the brain. Patient can have various presentation. Central pontine myelolysis, you can get only pons will be involved in that condition. It will be like a locked up syndrome. But here, throughout the brain, it can affect. But these conditions are very rare unless until you give sodium in a faster rate unnecessarily or IV push unnecessarily. Then you can patient can develop all these type of problems. Otherwise, in routine practice, these things are not very common. If you are following the standard protocols, these things are not very common. I'm not telling that when you give slow infusion, it will never happen. Not like that. It can happen even in slow infusions, but it is more common when you are giving faster infusions. Now, what is the treatment of SAADH? That is also very important. So, in a patient who is having hyponatremia because of volume deficiency, severe diarrhea, vomiting, all these things, you give volume with salt. In a patient with hypervolemia, like cardiac failure, liver failure, kidney failure, you prevent water to accumulate in the body. You try to remove with Lasix or something like that. Diuretic can be given and reduce salt intake. But what is the treatment when the patient is having normovolemic hyponatremia? You have seen what is the diagnostic criteria for SAADH. I am not repeating that, but the problem in the SAADH is actually there is water retention. We are only not seeing that water retention. That is a problem in SAADH, syndrome of inappropriate ADH secretion, anti-diuretic hormone secretion. So water retention is there because of increased natriuretic peptide. Water is removed, excess water is removed, but still there is water excess in the body. So here also, first line treatment is water restriction. So normally we give 1 to 1.0 liter per day. That is a water restriction. Next is furosemide. Don't think that furosemide will remove all the sodium from the body. You give some salt and give furosemide. That will remove more water than sodium. Sodium will be definitely removed. So you have to replace that also. We have no other choice. So you can give furosemide. The third option, you can still give 3% saline. I am not repeating that because we have dealt with the 3% saline in the last slide. If the patient is having clinically significant hyponatremia, even when he is having all these problems, you can still give 3% saline or normal saline, depending on the clinical scenario, that can be tried. The most important drug in this condition is SIADH. That is tolvaptan. The currently available drug in our country is tolvaptan. You can start 15 milligram OD. You can initially start 15 milligram OD. Within 1 or 2 days, it can improve the sodium levels because it prevents the sodium loss through the kidneys. So you can give tolvaptan 15 milligram OD or BD depending on the clinical scenario. You can slowly increase the dose. Maximum 60 milligram can be given, but you have to titrate the dose. If the patient improves rapidly, you can make it alternate days, once in 3 days. That depends on the clinical scenario. Conivaptan is available. It's a IV form of same drug. It's all these drugs are called as Vaplans. And one of the important use regarding this drug that also you should know, patient with cardiac failure, volume excess with hyponatremia, there are a lot of papers have come about tolvaptan. You can try this drug in this type of patients that improves the diuresis. Unlike Lasix, it will not remove sodium. So there is an advantage there, but still standard textbooks have not given this as a standard treatment for cardiac failure. But there are a lot of papers you should read about that. That tells you that this drug can be tried for better improvement in that type of patients. I think it is over. So I have completed this topic. I hope that you have learned something about hyponatremia. If you have any doubt, you can ask now. Hello.
Yeah, thank you, sir. Thank you, Dr. Gireesh, sir, for enlightening us in this hyponatremia topic. I
Okay.
guess you have covered me all that important points in hyponatremia, including
Okay.
the emergency treatment, how to treat when a patient comes in with the emergency manifestations like seizures, and how
Okay.
to give that 3% saline administration, that
Okay.
dosage. Everything was very clear, sir. And I
Only
guess
thing
most of the
you
postgraduate.
also know is one of the common condition of hyponatremia is urinary tract infection. You just follow your patients who is having urinary tract infection. And that is not given in any standard textbooks, and your
Thank you,
residents.
sir. It was a very good clinical insight. Every patient matters. And according to sodium, as you had said, the clinical condition as well as it's a very huge calculation.
Yes.
It was very insightful.
Thank you.
Thank you, sir.
Sir, regarding 3% NaCl, in case of raised ICP, how fast we can give 3% NaCl, sir?
So raised ICP, one requirement is you can keep it is not, you can give it fast like we give in seizures, storm and all. But only thing is you should keep the sodium levels little higher, more than normal, more than 145. That is a requirement. And that is, remember, that is only a short-term measure. Ideally, you have to take the patient for craniotomy or whatever it is. These all things will work in emergency room for half an hour, 1 hour. That's all. Don't think that this will be a permanent solution. Permanent solution is always surgical intervention that we have to try. In emergency room, we can try this. We can give it faster route, but there is a problem when you are giving faster 3% saline. There is a chance of central pontine myelinolysis. That also you should remember. But depending on the risk and other things, you can still give it fast. The dose is given. I have already mentioned that in faster rate. I have mentioned it. Give 3% saline 100 ml over 10 to 60 minutes.
Thank you, sir.
Thank you, sir. It was very insightful and very excellent lecture.
Okay.
Okay, sir. I think if that is all, then we will conclude, sir. Thank you, sir.
Okay.
Thank you, Dr. Gireesh, sir. Thank you, everyone, for joining us.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Corona वो नहीं लो बची जो हम तो जाएंगे